Welcome, everybody. And today we have Lori Metz. She's a licensed clinical social worker in New York. She actually has a private practice in Manhattan, and she has a history of working in hospitals and home care and with insurance companies. She's provided consultations, and now her main focus is her private practice, and she specializes in fertility. She's also consulted on patient safety. And the reason why I invited her today, and very glad to have her here, is because she worked on the first e-prescribing project in New York State. So I'm very excited to hear about kind of the history of e-prescribing. And Lori, thank you very much for joining us today.
Oh, thank you. This is a pleasure.
Excellent. So with e-prescribing, if you can share, just first of all, those that just don't even know how it works, like someone needs a prescription, right? They need to go to the pharmacy and pick it up. Like, how does e-prescribing work?
Well, e-prescribing is a way that a physician's office will write a prescription and it automatically goes to the pharmacy. And then when you go to the pharmacy, your prescription is there. And
Okay.
when you first go to register in a doctor's office, they will ask you the name of your pharmacy. And they'll ask you so that they could put it in the computer. And that way, when the doctor writes a prescription, it goes there and you're able to easily pick it up or have it delivered, whatever you prefer.
Okay. And do you know, is this like, is this just one program that's used nationally, or are there several, computer applications for the e-prescribing? How does that work?
Well, there's several different applications for it, but I really know much more about the history of when it
Okay.
started. Quite
Excellent.
frankly. But all of the electronic medical records now that the doctors use, they have their own e-prescribing systems, I would imagine, in them, so that
Okay.
up the history with that, and
Hmm.
then goes into, kind of like a hub.
Okay.
And the hub is like a cloud in many ways, or it used to be. And
Uh-huh.
so travel through that to the pharmacy of your choice.
Okay, yeah, rather than writing out, which is very hard to read in the first place, right? Writing out on the pad, handing it to the patient, having the patient deliver it to the pharmacy, simply just electronic through the computer, and you show up and your pharmacy already has the prescription ready for you.
Right.
Um,
That's where a lot of the patient safety issues came in, and a lot of the
yeah,
time came in, quite frankly,
yeah.
was
So that brings us to like why? Why did we decide, as a nation, our healthcare to use e-prescribing? What brought us to that point?
well, it started around 2000,
Hmm.
and what happened was the report came out called "To Err Is Human." So it was just obvious. It was just that we're making too many mistakes. That there's too many drug-to-drug interactions. There's too many unnecessary deaths that could be avoided. And then I think shortly after that, in 2000, the Institute of Medicine came out with a call to action. And their call to action was to start electronic electronic applications for e-prescribing. And
Hmm.
also at that time, they were talking about just entire systems being able to connect to each other like they are now, right? In the hospitals and the doctor's offices, and total transparency medically. But we weren't anywhere near that. We were just in the adoption phases. And I was in the first one in New York State. There were about six in total, I think 6 or 7 projects in total. And
Okay.
and so what happened was, I'm sorry, and what happened was there were 6 or 7 projects in total, and we had one of them. What we did is we partnered with a hospital system, and we started off initially with about 100 physician offices, wound up having 25 with the adoption. And the reason why is because at that point in time, the offices weren't connected for any type of Wi Fi. There were cabinets that would block any Wi Fi. There was no wiring. There were no places for computers. People didn't even think to have computers in their offices. And so we had to help people with every piece of the application, from workflow to learning how to turn a computer on to understanding what a BlackBerry was and why we call
Uh-huh.
it BlackBerry even though it's blue. And then working out, making sure that the pharmacies were aware to even look for a prescription when it was sent to them. So the adoption phase was challenging, but what really initiated it, in case I'm not really directly answering your questions, were a few driving forces. So one was patient safety. one, so that we could reduce some of the unnecessary drug-to-drug interactions, which was leading to early deaths and unnecessary deaths of people.
Mm-hmm.
One was the cost, just the cost in dollars, but also the cost in times in the physician offices and with staff. If you had a busy practice, you almost needed one full-time person to call the pharmacy, receive a phone call the pharmacy, pull the chart, talk to the doctor. It was incredibly time-consuming.
Ah, okay.
Okay, and the other was that lots of times if you went to one doctor, they didn't necessarily know all the other drugs you took. So they
Okay.
didn't have the ability to have any drug-to-drug interaction information. They
Mm-hmm.
also had to use these big books to look up prescriptions or to look up what a medication was. And
Uh-huh.
now they just had it on their BlackBerry. They were able to look at their phone and have this wealth of information right there to look up any drug and understand what it did. And so all of this information is now available at your fingertips, and that was huge.
I see.
But the driving force, I think, for the doctors was really the top two that I mentioned, right? One was understanding the reduction in staff that they would have with the workflow activation,
Mm-hmm.
and the other was the patient safety.
I see.
Doctors, those were the two driving forces.
Yeah, that makes sense. That makes sense. Do you know if there's any research that shows a reduction in medication errors?
Huge research, yes. I don't remember it off the top of my head. What we're
Okay.
talking about, I would have to look, but
Mm-hmm.
there's huge research that does show this wasn't done lightly.
Mm-hmm.
It wasn't done easily, and it wasn't done for no reason. If
Yeah.
if we have, I think, 900 million phone calls to, or 900 million visits, and to a doctor's office, and 4 out of 5 people leave with 2 to 3 prescriptions, and each prescription
Right.
has to be handwritten, and then you have to be sure that it can be read, and then you don't even know if the patient goes to pick it up.
Oh,
Yeah.
so does the physician get a report saying whether or not the prescription was filled and picked up?
I think each physician has the capability to do that, whether or not they turn that on
Okay.
and look at it. But the insurance company does. And then when you go to your doctor's office, if anybody goes to visit the doctor, they
Mm-hmm.
know the doctor will run down a list of medications that you take. And you'll sit
Oh.
there and say, oh, I never took that. Or, oh, yeah, I take that. And then
Uh-huh.
I need a refill on this. And then with one click of the button, they either check off that you're still on it or that you
Yeah.
refill or.
Right. Yeah. I get the automated calls. Because with prescription, you get the automated call of prescription waiting, or you need your refill
Reminders.
made. Yeah, the reminders. Yeah, it's
Yeah.
really interesting. So moving forward, like, what are some considerations that people ought to have, or regulators ought to have in terms of patient safety in regards to e-prescribing?
Well, in terms of e-prescribing, I think that that's pretty well looked at and reviewed and so ingrained at this point because all the states now require it. I don't think you can practice anywhere without using e-prescribing. Um,
Okay.
and so I think that that's really ingrained. I think the adoption of electronic medical records is almost full speed. I think that most doctors' offices have it. If they don't have it entirely connected, they absolutely have the e-prescribing component. And usually, I think at this point in time, even a solo practitioner has the billing component um, adopted.
Uh-huh.
I think the future is exactly what you're doing. I think the
Hmm.
future is in the telehealth medicine and looking at the regulations for that and the adoption of it and the patient safety issues around that. That's my perspective on it.
Yeah.
Now, I haven't worked in e-prescribing in many, many years, and I was really involved in the infancy of it. But, having heard
Yeah.
about
Yeah.
what you teach and what you do and now have taken the
Mhm.
test, which I'm glad to say I passed.
Yeah, yeah. Well, yeah, in terms so you've been there, done that, and you were successful with making the transition from simply paper and pen to electronic prescriptions.
Well,
And you had to help people with that implementation, which requires a lot because you have the workflow of the physician's office and the pharmacies, the
mhm,
coordination between the two, and the training of the staff,
mhm,
and getting people to buy into it.
right.
So I'm sure you ran across some obstacles with that, resistance to that, people being, wanting to do it the old way. So what helped you with what would where'd you find success in terms of your methods of helping people implement it?
Well, I think that the success when we did this pilot was defined by the fact that 25 offices got up and running, but that was out of 100. So success was defined in a very different way.
Uh-huh.
Today, it took years for e-prescribing to really be
Right.
full speed ahead. And there was so much research and so many people dedicated so much time from so many different, government agencies, local vendors, insurance companies, hospitals. So the adaptation and the implementation is the biggest part, I think. So in the beginning, they were thinking about pay for performance. So for
Mm-hmm.
people who aren't familiar with what paid for performance is, they were thinking about how to reward the physician or the facility for adopting it. And that doesn't always mean in dollars. Sometimes it means in training or in software or, in a variety of different ways. Sometimes it
Ah.
means reduced insurance revenue. So pay for performance is not always, oh, you do this and we're going to pay you a percentage of this for saving this money. Pay for
Mm-hmm.
performance, because it's kind of gotten a dirty connotation or a dirty rap.
Uh-huh.
And it's not necessarily a bad thing. It depends on how it's implemented and the purpose behind the implementation, and then the person who is adopting it, what they're doing with it.
Mm.
So the services that they will then render. So it's really multifaceted. In terms of the adoption, I think the biggest piece was the training and the human intervention. Now, when we first started, it was also just getting the hardware in place and getting the software in place and making sure that people felt the support of all the different parties if there was a problem. So in other words, if they had a problem with the BlackBerry, what they're going to do naturally is just put a BlackBerry down, or say we put it down, right? And say, forget
Yeah.
this, give me a pad, I'm too busy.
Right.
To try and do this. So
Right.
there had to be a lot of hand-holding and support in the beginning. This is
Uh-huh.
individual practice offices. And then it was changing, the workflow so staff could then do different things. It was training key people in the office to learn how to do it so that they can then be the person who would help the physician to learn how to do it. Because there was a learning curve. And I think at that point in time, people who were over 40 had a harder time learning than people under. Because in 2000, if you were 40 or over, you didn't grow up using a computer. And if you did use a computer, it was in your personal life a few hours at night. So it wasn't really this huge adaptation unless you were like somebody who was really into it.
Right.
And so that was a big piece. In today's day and age, everybody practicing uses a computer and is very comfortable with it. It's unusual for people not to be in.
Mm-hmm. Yeah, so I guess our challenge today is to get people to use technology more and more so for care coordination, coordinated care, sharing records, communicating with other providers, following up with other providers. That's the piece that seems key today.
I think the other piece, I absolutely agree with you. I think the other piece that seems really key is as people, and this is my personal opinion, but as people adopt technology for visits and consultations, whether it's medical or mental health or emergency, I think we have to be aware of our own limitations as healthcare professionals. So we need to know what we're comfortable doing, what we're not. And if we're not comfortable with it, then we need to be able to know who we can reach out to gain that comfort level or that education.
Yeah.
That's really key. Like, I think the fact that we're able to take an x-ray of somebody and send it someplace else to get a second opinion is fabulous. I mean,
Wow.
it's such a wonderful thing that we can do.
Mm-hmm.
Emergency room, the radiologist is on, and you need to send it to a different country in a different time zone. We do that today too. So there's a very expedited way of handling things.
Mm-hmm.
But my concern is more the individual provider feeling comfortable with their own limitations. Care coordination is great. A family meeting is great.
Mm-hmm.
Family members in different places.
Yeah.
I'm just, it's really that one-on-one contact that concerns me.
Yeah. Excellent. Well, thank you very much. And
Thank you.
for those that would like to reach out to Lori Metz, here's her website. So again, she's in Manhattan. You can go to her website at lorimetz.net. So it's lorimetz.net. and look at the services that she provides. And again, she specializes in fertility. So thank you very much, Lori. Greatly appreciate your time and sharing with us the history, because there's certainly a parallel between the process that it took for e-prescribing as what it's taking for telehealth and care coordination and other things. And it's important I think it's important to know why it is that we're doing what we're doing. So, we're doing e-prescribing, we're getting those alerts for a reason, because it has helped with patient safety and efficiency.
Yeah, that
So,
shows. Thank you for your interest in it.
excellent. Thanks a lot, Lori.
Okay, thank
All right,
you.
bye-bye.
Bye.